So I'm going to try to make us catch up on time. And I think a lot of the data that I'm going to talk about, you've heard, and I'm going to summarize it a little bit for you. I think what I'd like to do, though, and if there's other health systems in the room, as we look at data about what's effective, and I think that we just talked about some of those, I'm going to challenge the other health systems to take this playbook and start enacting it a little bit. Let's get concrete about this. So first of all, I think as some of the folks had said, let's keep calm. I'm not an expert in gun violence. And I think the key that we're talking about at Northwell is depoliticizing this and looking at it as the epidemic. However, I will admit to you that I am a good person with the numbers. I'm an outcomes researcher. I look at big data all the time. And I asked a group of my colleagues in my research center, just go in without an opinion and tell me what the numbers are. And you've heard a lot of these numbers already. First of all, we frame it as an epidemic, just like any other epidemic. When we were looking at it, we came across this map, and I think someone mentioned this earlier. This map is 2014 HIV epidemic. It looks very similar to the hot map. We call these a heat map. The hotter the color, the higher the density of mortality and morbidity in HIV. This looks just like a gun violence map. It's along the coast, it's in the cities, it's affecting minority communities. And I was an intern in 1991 at Jacobi Hospital at the height of the crack epidemic and the AIDS epidemic, and every day I went to work, dozens of people died in front of me. And I was in the midst of a political nightmare. People were talking about sex education. The right was angry, the left was angry, there were protests in the streets, and people were dying everywhere. And they were dying in front of me. I thought, this is never going to get fixed. There is no way out of this nightmare. And lo and behold, there were some science discoveries that this was a virus. It's a retrovirus. And we learned some things about how the virus was spread. And this is the vector. And the job in science was to prevent this vector from entering the body. And then if it did enter the body, the job of the healthcare systems were to treat those people and allow them to live a normal life. I sponsor AIDS Week lecture every year at Northwell, and we invite a speaker in to talk about it. We have one of the largest AIDS programs in New York State, headed by the really amazing Dr. Joe McGowan, who's been fighting the fight for 20 years. And this is the slide that we opened up our conference with. Now, there's two things to look at here. One says, end AIDS. It's in front of us. We are actually going to end AIDS as an epidemic. I did not think this was even a word you could talk about. So that's one part of the slide. The other part of the slide is a long list of things that health systems are doing. And this is the challenge to health systems. I want to see the same list of evidence-based interventions that every health system is doing across the United States. Some of those things on that list are things that you all think health systems should do, right? We look at immunizing people. We look like treating sick people. But look at some of the other things on that list. Targeted housing for people suffering with AIDS, right? Hotlines for education 24/7. Drug availability in our pharmacies, free of charge if you have HIV positive and you run out of your medications. PrEP programs, syringe exchange programs. These are things 20 years ago, I don't even know, how would I have a conversation about these things 20 years? I didn't even have the language to talk about these things. But science didn't just research the vaccine, they did public health research, they looked at housing, syringe exchange. We need to look at these and solve problems right now because this is in front of us. I mean, here's the hotline in New York City that you call. If you run out of your medications, you call there and you get free medication. You would not dream of this before. This is our HIV Hot Map that we have in our AIDS clinic. Joe McGowan will look and see if there's a positive titer of more than one in a cluster, in a county, in a neighborhood, in Long Island, and he will send his team out. We have a van that we send out to that community, do education, we do prevention. Think of this, but gun violence. And you can do this. We can study it. We can look at it and we can affect change. This is a genetic cluster of a virus, and we can look at the resistance to that one person's virus and anticipate what may happen. So you have a public health phone call, you have a public health attack on housing and interventions and educations, and you have science. And I think just as you were listing before, we could do all of these things together in the gun violence area. And health systems can do this. We're so big now that we have enough purview over different things that we can do it. Look at this number. The goal for End AIDS in New York City was to hit below 1,000 positive new HIV titers by 2020. 2020, we're going to go below 500 in New York City. That is remarkable. That is almost an end to the epidemic. We're really close, and it's a lot of hard work. It was a sense of this is an emergency, right? We rang the bell. This is an emergency. Scientists much work hard to create a sense of emergency and then take on this challenge and attack it. There's the map for gun violence. Looks familiar. It's a hot map. Where does it happen? Here's the vector. There's the virus. We got to prevent it from entering bodies, and if it does enter a body, we got to treat people appropriately when it does. And that's our job, to prevent it from entering the body. That is the vector. These numbers we've heard. We're up to 40,000 a year. It's the equivalent of motor vehicle accidents, but it's increasing every year. This epidemic is right in front of us. We're healthcare systems, and it's just getting worse and worse. As we heard, it affects urban communities, minority communities. Actually, a lot of the violence is between people who know each other, and there's conflict. The lasting effect on children and adolescents, I have 2 teenage girls. It devastates them. The literature is on people who are actually near the violence. What we don't know is some of the violence, the issues for people that are just hearing about it. And I think it was alluded to, most people don't get it. 60% of gun violence is related to suicide. And it's related to the fact that there's a gun when somebody's depressed that's available. And what's really disturbing when you just scrape the surface of the data is that guns are an extremely efficient machine at killing yourself. 80% success rate. It's hard to say the word success when I say suicide, but compared to other forms of attempts, such as medications or self-harm, they're very low, 10%. Attempted suicide is a cry for help. When somebody attempts suicide and they show up in our ER, we wrap services around them, we treat them. You can't do that if you've killed yourself. Teenagers who do self-harm, we take care of them. Guns do not enable us to do anything. So when I want to think about, there are 4 key areas that we think about now, and we're going to start moving through this at Northwell. And I'm going to go through these really quick. There's obviously policy issues, and policies are effective. Universal background checks show about a 10% reduction in homicides. Healthcare-based interventions, many people alluded to this, training our doctors to talk about gun violence with their patients. A depressed teenager in a house, if you talk to the families about gun safety in the house, there's a dramatic reduction in violence. But we have to do it systematically and in every encounter that we move in. We look at school-based programs. This is where the data is a little shaky, and actually where I think to the point of we need more science. We're doing a lot in schools that I'm not sure is helping anybody. I actually am married to a clinical psychologist, and I think much of the early data shows that many of that effort we're doing is harming people. And then there's a lot of really good data that we're seeing the beginning of in community-based interventions. I mean, look at the reduction. If you do a focused deterrence, like the hot map that I was telling you about, if we could look at hot maps of violence and send SWAT teams in without guns, but with education, with behavioral interventions, with way to de-escalate conflict, we could actually show reductions in that. So those are some of the tactics. I want to just put this up here. I'm calling it the secondhand smoke problem of gun violence. And I know this because living with teenagers who see on their phones all this information about gun violence. They're going through drills in their schools. We're seeing a skyrocketing of anxiety and depression amongst adolescents and teenagers, and this is not helping. And we may be doing a lot more harm. This may be the thalidomide of gun violence. Really quick, at Northwell, we've put our categories. We have 4 categories that we're approaching this problem with as a large health system. We're looking at communication, preparedness, prevention, and advocacy. And I'm going to cover those in 19, 18, 17 seconds. I got it. Well, communication. We're here, we're communicating, we're talking, we're bringing people together, right? This is what we're trying to do. And I think this is my favorite cartoon. We're trying to de-escalate. This is a public health crisis. We want everybody to calm down. We're not trying to take guns away. We're trying to prevent the vector from entering the body. It's not that complicated. And Michael, thank you for your leadership in this space. He's been out there talking about it, bringing it into the public health sector, and I think we're having some success. The other space is preparedness. This is sad. Health systems are big. We have large crowds. We need to be ready for an active shooter. We've started to teach our folks in our hospitals, in the schools in our neighborhoods. We even have an app now for an active shooter that will alarm and alert people to that. And tragically, we're also working on how to stop the bleed in case there is an active shooter and somebody is wounded. We want to know how people should treat them. So that's an effort on our part. Prevention and screening. This is something that I think every health system has to do. Take an inventory of what you're doing across your health system. We have 4 major screening projects that we think we can weave in gun violence into. So ESPERT we have screened 1 million people for substance abuse in our health system, in our ERs, in our primary care centers. And we do brief interventions. Now, if we try to understand how does gun violence play into that brief screening with substance abuse, maybe we can get a leg in on the gun violence issue. We have a domestic violence screening program. We have a child abuse screening program. In all of our emergency room now, we have automated triggers that alert people to whether or not somebody might be a child abuse victim. What if we put in something around gun violence in that area? And last, and I think which has got a tremendous opportunity, is our social determinants of health screening that we're building into our electronic health record. We're going to look at how do we adopt some gun violence ideas in that space. And all health systems are doing this. These are immediate things that we can start looking at. And then the big point is we got to study, does this work? I'm looking at our public health advocates here. Last, advocacy and research. I think we've been ringing this bell since the morning started. The Dickey rule really killed, not directly, but indirectly was manipulated by the gun lobby to reduce the research in this area. So we are calling, I just want to show this slide for a second. For those of researchers in the room, this is called a forest plot. It's a meta-analysis of randomized controlled trials of highest quality for public health interventions to reduce HIV. Each one of these dots is a big research study. And what they do is they summarize all that data and they come up with an idea and then they attack it from a public health standpoint. If I tried to show you this for gun violence, I'd have like no dots. I'd have no data, okay? Not high quality, federally funded research of randomized trials, and I have 0 time. Lastly, we're asking for everyone to come together, health systems across the United States, to collaborate, share data, share best practices, and maybe we can start driving the research agenda. Maybe we can push the federal government, the state governments to fund us to do this research because nobody else is going to do it. And maybe we can start talking about a way to end this epidemic if we all stick together on this. So thank you very much, and I'm going to have David come back.